The COVID-19 pandemic is illuminating the devastating toll that unequal distribution of healthcare infrastructure has had on our city's communities of color and in the outer boroughs. In 2020, Manhattan had 6.4 hospital beds for every 1,000 residents, while Queens had only 1.5 hospital beds for every 1,000 residents. Similar disparities exist in the Bronx and in Brooklyn. So communities have heard a lot of lip service from policymakers about addressing healthcare system inequities. What would you do as mayor to ensure that this healthcare infrastructure is distributed more equitably? And my first up, General Sutton.
Thank you so much. Well, I think a good place to start is with the data, as you said, that highlights the disparities. But then I would also want to take a second and third order look at that data to see what the disparities or what the relevant data would suggest in terms of access to trauma, level 1 trauma centers, as well as primary care centers. I mean, I think there's a whole systems approach that has to go on when it comes to healthcare infrastructure and access. So I think that's the first place I'd start. I'd also say in terms of, as a subset of healthcare, mental health care, very concerning when you see all of the seriously mentally ill, untreated individuals, New Yorkers who are putting themselves at risk as well as others at risk. And over these last several years, the hospital beds, the long-term treatment care for the mentally ill have gone way down, while we've got more and more folks, both the decarcerated individuals from Rikers, as well as just the wear and tear of the pandemic over these last 12 months. And there has to be a very serious reckoning to bring those things back together and make sure that we've got the right infrastructure and access to quality health care for everyone.
Let me ask you a follow-up. If you could provide a few more details specifically in terms of mental health care, who would you charge with doing that, and how can we make this better?
Sure. I think in terms of mental health care, we need to understand that this is linked to homelessness. It's linked to the criminal legal system, and part of what my focus would be going forward would be to put the justice back in the criminal legal system. But we need to understand that it's not just a single issue that can be dealt with separately. So what I would look to do as a systems plan would be to both bring the clubhouse system, the fountain house system to scale across the city. Proven system. If you haven't visited, you need to go visit their program. I would also double down on the secure diversion programs, keep the mentally ill out of the prisons. I'd also double down on the staffing at the shelters and in the ER so that we can intervene early and make sure that we've got social workers who are working with the police when it comes to emotionally disturbed persons' calls, and we make sure that our mentally ill individuals are not just trying to survive on the subway or on the sidewalk.
Thank you.
But get the care that they need.
Thank you. And so I would ask the same question about healthcare infrastructure of Mr. Stringer.
Well, let me nod to Carlos and Loree. They've identified, I think, critical programs that could actually help invest in communities. But I think a broader question that I think the next mayor has to answer is, are we going to take a sledgehammer to the status quo, or we're simply going to manage people's illnesses? When my mom died of COVID in a Bronx hospital in April, the doctor there said to me, this is not just a disease that impacts older people with pre-existing health conditions, as my mom certainly had. He talked about the Bronx and talked about people of color, Black people, Latino people in their 40s and 50s were dying because they suffered from diabetes and pre-existing health conditions, asthma, and a whole host of issues. And when you overlay what was happening in the Bronx, you saw the dirty bus depot stations and the bad decisions government made to build things that ended up polluting the local neighborhoods, and everybody knows it. So we need to redesign a healthcare system that does two things. One, we have to do the prevention work and solve these health disparities. That means programs, but it also means we've got to get the Department of Health back in the game. We got to merge H&H and DOMH so that they are proactively looking at ways to prevent the next virus or the next healthcare crisis. And that means we also have to not just invest in hospital or local clinic infrastructure, but we have to invest in personnel, the nurses, the doctors, how we're going to grow that healthcare in the communities. And that's how we will end those disparities.
Thank you. Thank you. Ms. Wiley. Hi, do we have Ms. Wiley?
Apologies, I didn't realize I was muted. Look, one of the things we have to address, experience bias in the healthcare system that costs lives, frankly. I mean, Rana Mungan in Brooklyn, who was a middle school teacher, 30 years old, was turned away from testing 2 times, got so sick and ultimately died of COVID at the age of 30. And that was not just about whether there was a hospital present, it was how she was treated when she got there. And so it's critically important that when we talk about healthcare infrastructure, we recognize it is preventive care. So we've got community health clinics that are part of the front line of primary care in a lot of communities of color that don't have adequate services, and they serve as important services. They're at risk of closure right now because they stepped up in COVID and they stepped up without getting support. And that's about $100 million. I will have a moral budget, and that moral budget will ensure that those community centers, health centers, stay open because we have to preserve that infrastructure. We have to save our independent hospitals that are at risk of closure, who are not sitting on billions of dollars of endowments the way some of the other systems are, who did not, frankly, take on the care and fill the beds that they had with patients. So we will do that.
Thank you. Mr. Menchaca.
Thank you. We have to bring healthcare to the people. And part of what I want to do is bring infrastructure into schools and really build out community schools in a way that allows for not just a nurse, but a larger healthcare access point for young people and their parents. Second, I think that what's really important is that we learn from COVID and what's happened in COVID. So many times people were not able to know whether or not they needed to go to the emergency room. Working with the Red Hook Initiative in Red Hook and local volunteers, we actually built out a system that brought telemedicine, actual doctors, working with the Department of Health and other volunteer doctors to people. And telemedicine works. I think we need to bring that kind of infrastructure to people so we can get a primary care relationship when we can't bring fast enough physical infrastructure.
Thank you. I want to ask you a follow-up about that. So what are some best practices with telemedicine that happened in Red Hook through the Red Hook Initiative that you think are scalable, and how would they be scalable?
Absolutely. So there are 2 things that are really important about what we learned. One is that the actual caller needed to be coming from a trusted source. Red Hook Initiative and the council member's office, my office, were critical to getting the door open, literally through the phone and saying, hey. Second, we spoke the languages. English, Spanish, and Mandarin were the spoken language of our volunteers. Third, when we brought people who didn't know when they needed to activate, there was, and these are now more plentiful, abilities for volunteers to kind of go through questions that allowed people to understand whether or not they were in danger. And at that point, that's when we connected it to the Department of Health and other doctors that were able to connect to people. So the first thing before we even get to the doctors is a trusted face, someone that can open the door, and that changes. If you don't have that, none of the things that we build will get directed and connected to our communities.
Thank you. Thank you. Ms. Morales.
Thank you. So, the first thing I would say about dealing with this infrastructure is that we first have to expand the front end, the preventative care issues. And, rather than get into all of the social determinants of health that have been referred to as pre-existing conditions, the environmental justice issues, the housing issues, the lack of nutrition, appropriate nutrition. I'll talk about sort of from point of beginning, expanding preventative care. New York City has fewer sites per person than other cities right now in terms of access to primary care, which ends up having our communities rely disproportionately on emergency rooms. So I would look to increase local community-based care through increasing integrated community health clinics. I think we also need to provide and expand health educators and promoters, folks who are culturally relevant, culturally competent, and linguistically appropriate to provide community and neighborhood-based interventions and supports and education so that it's accessible. And finally, I think that one of the things that's important to talk about is that our CBOs have to be an integral part of the ecosystem of what I would consider a multidisciplinary approach towards addressing the shortcomings of our current system and also just rebuilding that trust that I referenced earlier.
Thank you.
Thank you. No, it is shocking, the disparity of hospitals, and many hospitals that have closed in the outer boroughs. We need to do a couple of things. We need to ensure that we shore up H&H. It is a critical asset. We relied on it heavily. We need to have H&H and the private system work together. We may not be able to build a full new hospital in every neighborhood, but people in all neighborhoods need to have access to any hospital in the city. The ambulances can cross the bridges. This is a possibility. But we also need to rely on telehealth and virtual appointments to spread access more easily across the city.
Thank you. Thank you. And you talk about shoring up H&H, and we'll get to talk about that a little more because I have another question coming up that touches on that. But for now, I'll move on to Mr. McGuire.
Yeah, I will amplify, and I know you might talk about H&H, but H&H, I think, given what we talked about in terms of healthcare inequity, is going to be at the center of this. We already now have 6 of the express care centers. I would be focused on increasing that number and making in the highest at-risk geographies in the outer boroughs that we have these express care centers. So I would make certain that we increase that by many-fold to make sure that they were there. And in addition to the urgent care centers, I would incentivize the development of primary care facilities within the boroughs so that the people in the boroughs have a primary care physician. And for those incidents that are the most acute, we should have the professional in the primary care facilities, and the people would be part of a network. So where those professionals were not within the primary care facility, they could access those networks within the boroughs. And so I would make sure that the healthcare existed with the boroughs, and I would do that based on many of the programs that are now under H&H. Especially, we're going to need programs and infrastructure to deal with the lingering impact of COVID, which has been very, very little talked about. So we've talked about getting COVID, we've talked about vaccine. What about those who recovered from COVID, who have lingering conditions? We need the infrastructure.
Thank you. But I do have a follow-up question for you, Mr. McGuire, because you talked a bit about incentivizing, and I know before you've talked about different ways of zoning and financing. So can you talk a little bit more about that, particularly as it relates back to increasing hospital beds?
Yeah, one of the things that you can do is to incentivize the development with the community involved and have this as a priority, and make certain that you can adequately compensate the primary care physicians so that these become places where they want to work, to be part of the community. And so I would make certain that in addition to developing the infrastructure, that we attracted the best physicians so that the quality healthcare that all of us deserve were available locally. And I think we can create incentives to build. I think we can create incentives for doctors to perform, and nurses assistants to want to be part of these communities and be compensated at the appropriate levels.
Thank you. Thank you. Next, I will ask Mr. Yang.
We have such a vastly unequal healthcare system in the city, where you have some of the best world-class research institutions in the world, and then you have massive hospital bed shortages and lower life expectancies in areas of the Bronx and Brooklyn. You have to try and solve for the lowest hanging fruit opportunities. Again, I reference neighborhood action centers in places like Queens, where right now they're not getting the right kind of primary care or access to urgent services. And then I agree with Kathryn that we have to make better use of the capacity we do have. I would love to be able to build new hospitals in some of these healthcare deserts, but in the interim, we should be utilizing more of the capacity in some of these hospital networks where they do have much higher levels of resources, and let folks know, look, you might not have the beds in the Bronx, but we actually can cross the bridge and bring you to NYP and these other facilities.
Thank you. Thank you. I guess my question for you to follow up on that is, how would you work between the different hospital systems? Because that's been a problem, and even for instance, in terms of COVID response, it's very uneven in terms of which hospitals have resources and which ones don't. And I guess my question to you is, if you're trying to distribute that infrastructure and that capacity more evenly, how would you get, for instance, public and private hospitals to work together, or public or private hospital systems to work together on that?
No, the perfect example of this is what's going on right now with vaccination, where again, you have people logging into public hospitals, urgent care centers, and the private hospital networks. And the private hospital networks don't share their data either. While we're in the midst of this crisis, we need to have a sense of the capacity in both public and private hospitals, and then have more leadership, frankly, in being able to connect citizens to resources right now for the vaccine, but also moving forward, if you have another crisis, to be able to see where you have capacity and where you have a need. This is the frustration that so many New Yorkers have, is that we have institutions and systems that are siloed and don't talk to each other. And one of the primary missions of the next mayor has to be to get folks around a table and say, look, like, we're still trying to get ourselves out of this crisis, and we cannot have you husbanding resources that are literally going to save lives if applied in a neighborhood like only a mile or two away. Like, this is a leadership exercise. It's an administrative barrier. It's not even really a technological barrier, because these systems have the capacity to actually share information if you actually just push them to do so.
Thank you. Thank you very much. Mr. Adams.
Yes, I often, sometimes when I hear Kathryn speak, I feel like she's a lost twin, because, we both just seem to get how we must do things in real time. That is the failure of our city. When you look at what they do in Boston with City Score, when you look at what we're doing in this city, not only are we silos, but as I state, we feed to crises. Why aren't we using telemedicine? I attempted to get H&H to embrace telemedicine so often prior to the pandemic. They refused to do so. Now they incorporate it, and they have hundreds of thousands of people who utilize it. I didn't get to answer the immigrant question, but one way of dealing with the immigrant issue is having our immigrants use credible messengers that speak the language and communicate, so we don't use the emergency room as primary care. A way to do that is to utilize telemedicine. Second, we need to build out one hospital system in real time of availability of hospital beds. And we should leverage our power. Many of these hospitals, the privates, we call them, they're using taxpayers' dollars. They get tax breaks because they're nonprofits. We need to say, it's time for you to come to the table and be part of a health and hospital system and participate in utilizing your buying power and your expertise. We have one citizenry in this city, not a Manhattan hospital system and an out-of-borough hospital system. They need to do more with those tax benefits they're receiving.
Thank you. Thank you. And my apologies to you, Mr. Adams, if you didn't get to answer the health insurance question relating to immigrants. I'd like to give you that time now.
No, it's about communication, and that's quite all right. I know it wasn't intentional. It's about communication. You saw during COVID, and we continue to see, Our leaders communicate in this city as though it's an English only speaking city. All the briefings around COVID, they were in English. We didn't reach out to the local various papers and the different ethnicity, the Bangladeshi community, the Chinese, the Spanish speaking community. That is the problem in our city. We continue to run this city like it's an English speaking city. 40% of Brooklynites speak a language other than English at home. We need to reach out to those credible messengers, similar to what we saw during the census tract and how we reached out to those local community groups. Many people are afraid to walk into the hospitals because they believe ICE will be there. They're afraid to get the medical care that they need until there's an emergency. I say let's be more proactive and not reactive, and we can get this done better.
Thank you. Thank you very much. We're still on the question about equity in healthcare and addressing the outer boroughs. And I am really sorry if I miss anyone in this, but I believe Mr. Donovan is next.
Yeah, I thought you might have ceded my time to Eric, which I
not at all. It's his time, you get your time.
Thank you, Sheryl. Look, I would agree with a lot of what's been said about this issue around hospitals and the need for the mayor to use their leverage. We should also remember that we are losing more hospitals even as we speak. And I've been working with Reverend Malcolm and a group of clergy to organize around stopping the closure of Kingsbrook. And there's still many examples we need to be fighting on right now so that this disparity doesn't get worse. But we've also got to ask a bigger question here. Even if we had perfectly equal access to hospitals, we would still have hugely different health outcomes for Black and brown people and others in this city. I know this because I've seen it over and over again in my work over the last 30 years in New York City neighborhoods. And what we need is a mayor who understands that every issue is an equity issue and would lead with a chief equity officer that would report directly to the mayor. I committed to that. My policy is my very first policy commitment as running for mayor. We need, as I said, in 15-minute neighborhoods, every neighborhood not just to have a hospital, to have primary care, to have emergency mental health, but also have access to fresh food, to a park, to exercise with your kids. All of those are critically important. And we have to close the wealth gap, because one of the real barriers to equal access to healthcare is the wealth gap. White families have 10 times more wealth than Black families in this country. That has to end. It's why I proposed equity bonds that would give every kid born in New York $1,000, and depending on income, up to $2,000 a year, which means you could graduate high school if you were born in poverty in New York with $50,000 to put toward building a life of opportunity.